Well, I'm not sure if I can be heard. Can I at this stage?
Probably still on mute. I can't hear anything.
Okay, well, I hope you can hear me. My name's Ann McNeill. I'm a professor of tobacco addiction at King's College London, and I'm chair of the Mental Health and Smoking Partnership. ASH and the Mental Health and Smoking Partnership have put together this webinar, which is an opportunity to hear how mental health trusts have been effectively implementing NICE guidance PH48, which is acute maternity and mental health services and smoking. I'd like to extend to you all a really warm welcome and particularly thank our 4 speakers who are going to talk about local case studies this afternoon. Apologies that it is a bit of a London-centric group of case studies, but on the briefing, which I'll show in a minute on the next slide, there are many other case studies from around the country. Unfortunately, however, representatives from these trusts weren't available to present today. So if we could move on to the next slide, please. So ASH has produced an evidence into practice briefing on NICE PH48. The briefing provides guidance, advice and case studies on how to implement the NICE recommendations, which are grouped into 4 themes: leadership, providing support to smokers, supporting staff and communication issues. And today's case studies are going to pick up on these themes. The briefing is mainly aimed at professionals working in smoke-free mental health services, but it may also be of use to people working in local public health teams and associated services who are also supporting PH48 implementation. So if I could have the next slide, please. I'd encourage anybody who's listening to this webinar, if you'd like to stay up to date with the latest resources and hear about future webinars in this area, please join the Mental Health and Smoking Information Network. We've got over 400 people, organisations rather, on that network, and it's very useful at giving you these up-to-date resources. To subscribe, you email admin@smokefreeaction.org.uk, and these slides and the webinar will be available later, so you can get the email then. So just before we start then, just a comment on questions. You can ask a question anytime during the webinar using the question bar, which is on the right-hand side of your screen. If you open that up, you can then send us as many questions as you like. Only the organisers will see the questions, and we'll put those to the speakers at the end of the webinar. But if we don't manage to answer all of your questions, we will give responses in writing after the webinar, along with any other follow-up resources. So please do put your questions in as we're going along, because otherwise it's easy to forget after the 4th talk. Okay, so I'm now going to hand over to our first speaker, who is Mary Yates from the South London and Maudsley NHS Foundation Trust. So Mary, thank you, and over to you.
Thank you very much, Anne, and hello and good afternoon, everyone. I hope you can all see my screen. So, as Anne said, I'm Mary Yates. I'm a nurse consultant at South London Maudsley NHS Foundation Trust, and I'm really delighted to be able to be with you this afternoon. I'm going to speak to you specifically about communication that we did around the smoke-free policy, and I want to acknowledge Anne's help and support, together with Dr. Debbie Robson from King's College London, who have been with me and all of the team here throughout our smoke-free journey. And we're just about coming up to our 6th birthday of our smoke-free policy. So in the next 10 minutes, I'm going to talk to you about the communications that we did initially around engaging with people and attracting people to the idea of having a smoke-free policy. And I focused that into 5 different steps. And then I'll move on to talk about the implementation phase. And I'll specifically talk about 2 things there. And finally, I'll say just a little bit about where we are now. So to begin, these 5 steps that I'm focusing on start, I think, with attracting people to the idea and the benefits of having a smoke-free policy. And it's initially really all about taking time to listen rather than coming into an organisation and saying, right, we've got to introduce a smoke-free policy, so this is how we're going to do it. I think it was so important to make a lot of time at the beginning for actively listening to what people's ideas were about what that would look like. And we did that through a series of one-to-one and community meetings, because not everyone feels able to say what they think in a community setting. And on the screen there, you can see a photograph of me, because we did that community engagement not just within our hospital, but throughout the community. We did roadshows. So here's an example of me on a big screen in Brixton shopping centre. And at places like that, where lots of people in the community gathered, we positioned ourselves so we were able to speak to people about what were their ideas and thoughts about supporting people to stop smoking in a mental health care setting. We also had a really prompt response to complaints, and we turned complaints around within a week of getting them, because people who did have questions and concerns about the idea of a smoke-free policy, we felt it was really important not to allow those to gather momentum and to get pace, but we tried to intervene really quickly to allay people's concerns and fears and just really continue to set the tone for supporting people right throughout the smoke-free journey. And of course, we used all the traditional ways of communicating with people through posters and banners and leaflets, and they cannot be underestimated, because the power of having a big banner outside the hospital gates is really very important. And so these old style ways of communication still work and should be part of the overall communication strategy. And we also had a web page and an advert, and of course I even started to use Twitter, which was a bit of a challenge for me initially, but it's nevertheless another really important way of connecting with a whole wide range of people at all sorts of different levels in the community. And finally, I think one of the most important things that we did in that initial phase, we set up a smoke-free ready email so that people were able to reach out to us wherever they were, but with a question, a comment or a thought, and then get a personal response in a very short space of time. So all of this attracting people to the idea of smoke-free was all about holding the space for having that conversation and getting people to imagine what it would be like to have more time in the day, to do more therapeutic activities, to use garden spaces in the hospital in a different way. And it was really very liberating to see how people were actually very willing to engage even in those early stages. And the next phase, I'm talking to you about moving on and shifting the focus more from listening to giving of information and starting to persuade people. So some of the people who might have been sitting on the fence around the idea of having a smoke-free policy, just starting to take some of those people off the fence and onto the other side by sharing evidence about the interest that people with mental health problems have in quitting and getting support, providing reassurance and demonstrating how other people have actually achieved this success, and sharing those stories and building hope. So I think I would say this, if the first stage was about clearing the soil and getting ready for planting, this second stage is really about putting some fertilizer on the soil so that it's ready then when those seeds are planted. Now, my next stage I've called bridging, but I think one of the most interesting things about the Smoke-Free Initiative for me when I first started to work in this area was that people were constantly trying to ask, well, who should own this? Is it a physical health issue? Is it a mental health issue? Is it a public health issue? Is it a primary care issue? Is it a secondary care issue? And so there was a lot of this trying to shove it around from one place to the other. And I thought what was important for us to do in this bridging phase of our communication program was to see how we could connect other people to this issue and to highlight the fact that smoking cessation and smoke-free policy implementation isn't just any one group of people's business, it's everyone's business. It isn't just a clinical issue, it's also an issue for people in health and safety department, for the estates department, for the occupational health department and the human resources department. So I think this is about, for me, finding common ground and finding where you can draw some more people into your program of work so you can develop joint plans and make sure that you can find opportunities for other people to get engaged that are not just clinical staff, because they can really be crucial to achieving the goals that you'll need to in bringing about PH48. Step 4 is all about asserting, and this is where you need to be a bit clear then about what exactly it is you need people to do, how you need practice to change, and how you need the behaviours and the services to change. So this involved developing protocols, templates, checklists, clinical guidelines, action plans and pathways, and distributing them in the usual ways. So using committee meetings, using the intranet systems that you have, and the old traditional style team meetings. But I would say the most important thing about this stage is making sure that everything you do is underpinned by co-design with service users, patients, family, and carers, so that the protocols and the templates and the checklists you provide are going to be relevant for practice. And finally, I just want to say briefly that there are times when you need to just disengage, when the communication you are engaged with isn't getting you anywhere, and you need to step back, and rather than just keep going round in circles, you need to pause and reflect and then come back again at another time when emotions are not so high. And we try to study the patterns to inform how we approach different groups and different teams, and look at where the resistance was and how we needed to deal with that, and sometimes how we needed to move on from that and focus on and push on the doors that were open or unlocked, rather than spending a lot of energy arguing with people who were not ready to change yet. Now, moving into the next stage of my conversation with you, I'm just going to say a couple of things about communication in the implementation phase of the smoke-free policy. And I think some of the most important things here are about collecting and sharing good quality data. And I'm really delighted that Professor Ann McNeill and Dr. Debbie Robson are able to support us to get it planned, so that we established an integrated referral system for communication of referrals. And that allowed us then to have a live dashboard. So on the screen here, you can see that if a busy staff member met a smoker, identified them, they were able immediately, very quickly, to refer them. And you can see there that that's the slide shot of the dashboard. 58% of our patients this week in hospital have been referred for support. So the communication is immediate, clear, it's in real time, and it just makes our work very easy. We also, of course, have had Sequence to help us, and we had, again, live dashboard updates. So regardless of whether you at borough level, team level, individual patient level, we could all see how well we were doing, and we could all see our action plans. We also have the same process for our incident reports, so we could track and monitor what problems were in what locations, and we could respond to those whenever they occurred. And of course, finally, we had some really good publications, and I want to pay tribute to Dr. Debbie Robson for her assistance with the wonderful publications describing what really moved us forward, helping to focus on how much time we had been spending facilitating smoking, and also helping us to see how much better our services were once we introduced the smoke-free policy. And these were hugely important to help to keep us moving forward as we progress through our implementation phase. Now I'm going to just speak about a few of the creative responses that we've had to the challenges. We do a lot of huddles where if we have incidents in our ward, we gather together the people involved and we think about what actions we need to take so that the communication is immediate, but it's collectively involving everyone. We've introduced a speaker at one of our hospitals, and this is connected to some loudspeakers on the outside of the building. So if the receptionist sees somebody breaching the smoke-free policy, the receptionist can just press on this button and a message will be given to the person who's breaching the policy. So again, it's another really important way of communicating with everyone about our smoke-free policy. We give these cards to anybody who's breaching the policy. This is an idea I borrowed from colleagues in Belfast, which is a really important way of giving people information about the policy, but on the back of the cards, giving them information about where they can get support. These are stickers that we use on our medication charts, prompts reminding our nurses to continue to offer NRT or varenicline or e-cigarettes to our smokers, because our smokers don't always accept those offers of support when they are very unwell and newly admitted. So just continuing to communicate that. And here's a fantastic idea introduced by my colleague Andrew, who wanted to make sure that every new patient got offered NRT on admission. So this was his idea of giving tea and NRT. So a cup of tea with the reminders about the support that's available printed there on the cup. And finally, here's our sniffer dog, Danny. It's another public way of communicating to everyone that we are enforcing the policy, and we're continuing all the time to look for any evidence of tobacco or cigarettes or lighters. Now, the final part of my talk is just saying a little bit about where we are now.
Mary, just able to just wrap this up in about a minute, if that's possible. Sorry, really sorry to interrupt you. Thanks.
This is my last bit, and thank you, Anne. So this is a picture of me celebrating somebody's success story, and I want to say the importance of doing that cannot be underestimated, and we do that through having, well, I'm afraid I have a lot of tea and cake with people to celebrate their success, but also shout about people's success through blogs, vlogs, and news briefings. And this is my last slide, that I think we've got to continue to maintain the momentum through connecting people with programs, national programs like the Stoptober program, which is just about to kick off for this year, and continue to change by supporting our offer for people to switch to e-cigarettes, which is a real priority for us at the moment. And finally, in PH48, we were advocating for one site-based advisor in every hospital setting. But I would say our experience is that this is just simply not enough, because we have far too many smokers for one person to adequately support. And we now have 12 full-time advisors integrated across all of our care pathways. And this then enhances the communication that we can have with those smokers and with the teams who care for them. So thank you very much, and I look forward to your questions at the end. Thank you, Anne.
Thanks so much, Mary. Sorry to interrupt you. So we'll move swiftly on. That was a really interesting, clear presentation, so thank you. So our second speaker is Raminta Astra-Uskaita, who is based at the West London NHS Trust. So thank you, Raminta, and I'll hand over to you. Please do keep the questions coming in. I know there were some audio issues, so I hope they've been resolved. Thank you. Thanks, Raminta.
Thank you, Anne. Good afternoon. Thank you for inviting me to present our case study and talk to you about how we implemented the NICE guidance PH48 on smoking in acute maternity and mental health services to our smoke-free training programs in West London NHS Trust. Let me give you some context about our service. We have a dedicated smoke-free team comprised of smoke-free leads, so myself, and 2 tobacco dependent specialists for mental health. We deliver level 1, level 2, and bespoke training to 3 acute mental health hospitals and West London Forensic Service. We also support community mental health, healing community partners, and other trust services with training. The implementation of the smoke-free policy requires a competent workforce. We need to ensure that the trust provides training to staff, offering the appropriate mix of skills in order to meet the needs of tobacco-dependent patients. So it is essential that these smoke-free training programs are of the highest quality and reach as many staff as possible. Our trust offers NCSET accredited level 1 training in line with NICE PH48 guidance, which includes DBA, background knowledge of how smoking impacts on mental health, NRT, e-cigarettes, policy and support. Our level 1 training has been very successful, simply because we offer the required yearly refresher for level 1 training as recommended by NICE guidance. We provide training quarterly while also delivering many ad hoc sessions throughout the year. We aim to book new staff members within 6 weeks of their start date, and we also focus on delivering this training face-to-face, besides having our e-learning course available online. To maximize attendance, we deliver training on site and by encouraging friendly cooperation between wards. We also recruit internal champions to support smoke-free initiatives and practice, especially those at senior leadership positions, as they tend to be the most influential. And lastly, our training is delivered to all staff that have clinical contact with patients, including staff from pharmacy, psychology, and occupational therapy departments for a multidisciplinary approach to smoke-free. Our level 2 mental health and nicotine management treatment program is a 2-day face-to-face training. The aim of the course is to provide staff with intense evidence-based support in order to help service users manage their tobacco dependence in line with NICE and NCSET guidelines. This training has also been successful because we collect detailed training feedback from attendees, which allows us to improve on our communication, productivity, interaction. The role of Stop Smoking Advisor is accredited by NCSET and is viewed as a valuable additional skill. It is beneficial not only to our patients and the organization, but also to staff. The advisor role is embedded to staff personal development reviews in order to ensure the work in this area is acknowledged. And it is also a great opportunity to learn transferable skills, such as behavior change, motivational interviewing, CBT, and compassion-focused therapy elements, which are incorporated in the program. Additionally, the Trust provides mentoring and supervision following the training, as well as quarterly best practice meetings to ensure that the advisors are fully supported and confident when helping patients. Our smoke-free resources are easily accessible via the first smoke-free page, and we have a smoke-free box in each ward with materials and equipment available on hand. Lastly, we encourage and motivate our advisors through the Advisor of the Month Award. This achievement is widely communicated across the Trust. As a result of our successful approach, we had 219 staff attending Level 1 training, and 58 staff members became Level 2 stop smoking advisors in the last year, increasing from the previous quarter. This has led to more accessible support for patients, in-house stop smoking clinics, and increased smoke-free discussions on the wards. The majority of the training we deliver is bespoke. This has proven to be essential because we can address different service needs and specific staff groups, ensuring a relevant training which is significant to the work and transferable to everyday practice. We use bespoke training to tackle specific issues, and we always make sure that our training is engaging while providing a flexible setting and suitable delivery methods. So let me give you a couple of examples. Our Level 1 training for junior doctors at induction emphasizes different elements such as the brief advice and access to NRT, and it looks a little bit different from Level 1 training delivered to, let's say, community mental health teams, where importance of knowing effects on mental health, smoking effects on mental health, and referral options would be highlighted. Or, for example, if we observe one ward having increased number of incidents around e-cigarette use, we would deliver enhanced educational sessions around e-cigarette practice and safety. We monitor our training carefully. Here you can see an example of how we log our training events, attendance, and distribution across the Trust, which helps us to keep on track with our KPIs. Training evaluation is an essential part of monitoring our training quality. Overall, we can see that our training meets the expectations of the attendees and that our trainees feel well prepared to provide stop smoking support to patients. We do, however, face some challenges, probably like any other trust. First of all, the availability of staff to attend the training. We try to work around it by promoting training benefits and the importance of compliance with smoke-free policy, being very flexible, working closely with ward managers and senior management teams. We're also addressing the issue of high staff turnover, as we tend to have many bank and agency staff on wards. Currently, we rely on existing trained staff, and we try to train new starters as soon as possible. Sometimes we have specialists going in and supporting the wards. We also encourage ward managers to also train regular bank staff. Lastly, we still have quite a few members of Stop Smoking. We are currently working with Occupational Health Department in setting up a new smoking cessation program for staff, so we can support our staff as recommended by NICE guidance. The current main challenge is, of course, COVID-19. We have to make adaptations in order to continue delivering effective and high-quality training during this pandemic period. The smoke-free team has been working throughout the lockdown and we moved to remote learning very early in the lockdown. As soon as the lockdown began, we were delivering bespoke COVID-19 and smoking webinars to staff, and we moved on to deliver Level 1 training via Microsoft Teams. Training sessions were well attended, and we see increasingly more and more staff attending using remote learning. We will be delivering our level 2 training in October for Microsoft Teams. We will be using a variety of platforms, tools, and visual aids. Our training will still meet its standards, including important practical group elements. We found new ways to advertise our training by adding training dates to the new learning and development remote learning section, where staff are able to book themselves in the booking system. And we use the support of our key stakeholders to continue Maudsley training delivery. And we make sure that Maudsley continues to be on everyone's agenda throughout. The Maudsley team continues to be present at trust-wide meetings, emphasizing the importance of Maudsley policy and training during this time. And this is a key part and basis of the successful implementation of NICE guidance. Thank you.
Thank you very much indeed, Raminta. That was a really informative presentation on the importance of training. So we'll move straight on now to our third speaker, who is Di Hurley from the Central and North West London NHS Foundation Trust. Thank you, Di.
You can hear me okay? Hi, just get it to the start. My name's Di Hurley, and up until recently and for many years I was the head occupational therapist in Harrow Mental Health Service, mainly based at Northwick Park Hospital, and also the smoke-free lead there locally, as well as trying to support the trust through the many stages of going smoke-free. And it has been a journey with various stages. I really wanted to use my creative imagination to understand the perspectives of both staff and patients. I'm just going to change to the next one. Actually, I should be putting it on this one, shouldn't I? And okay, so making a drama to get out of a crisis. This is my next slide, because I felt that for staff, we really shouldn't underestimate or belittle the staff fears really in presenting the different restrictions to patients admitted to an acute mental health unit, some of which were very much in a city and really quite tough. And most of them have had to deal with smoking related incidents, and they all know colleagues who've had problems, including even at times a physical attack where smoking might have been a trigger. Practically everyone will have had to deal with verbal assaults in the course of their work, some of which might be linked to restrictions. In the training, they need a range of tools and resources, and we wanted to sort of bring it alive a bit. So I'll tell you in a minute how we did that. And for patients, for smokers who are admitted in an acute mental health crisis, we're asking a lot, and for their angry or distressed reactions can completely understandable, really, and we need to be ready for that. Most smokers use smoking as a way of managing and regulating their emotions, especially in extreme states. It's their go-to coping strategy. And even if we know there are many ways in which that's an ineffective and self-defeating strategy and worsens the outlook in the long term, both physically and mentally. I really wanted to guide us in having a really compassionate and sort of communication approach to doing that, and also offer a range of smoking cessation options, including e-cigarettes. So what did we do to make a drama out of a crisis? How did that come in? So back in 2016, and that was the stage at which we closed our garden to smoking. Because as before, obviously, first of all, way back, it was not having smoking indoors, and then it was they could smoke in the garden or on the grounds, and now we were going to take that step. So we made a film. It's about 7 minutes long, and you can see it on YouTube. It's has a range of media that we use in it. It has animation. It also has drama, actors acting out somebody being admitted to a unit, and it has a peer worker and an ex-patient who had quit, talking about their thoughts and experiences of quitting, and also staff about their experience of managing smoke-free and their attitudes to that. And much more recently, when we did the full Monty and went completely smoke-free in line with the NCSCT best practice guidelines. In the lead up to that, between 2016 and 2019, I wrote a drama with the help of peers and also patients who really helped develop this drama about various different vignettes about the scenario. So one of them was how not to explain smoke-free restrictions to an angry smoker, which in some ways it's quite funny, but I know that the reality is if you feel tense and it's a difficult conversation, it can sort of veer towards being a bit more coming across in a rather authoritarian way, which really doesn't work at all. And also how to use de-escalation approaches to have a much more fruitful and calm discussion with people about it. We've recently filmed that just at the end of 2019, and I'm hoping the film is pretty much ready. I'm not sure if we will be able to release it on YouTube. So we did all the other things that you've heard about from Mary and Raminta, and these are sort of very briefly the policy. A lot of negotiation has to go on board. It took a long time to get that agreed and everyone to be happy with it. And then you've got to let everyone know what it is, know it's coming, tell everyone and tell them again. And then the training should not just be death by PowerPoint, and this is where the drama came in, because we could use these films and dramas and also discussion following that to listen to the valid concerns of staff and identify what they needed and resources that would help them. And the tools that Mary spoke of, all the leaflets, posters, having all that very clearly on hand, clear guidance on really difficult issues such as managing Section 17 leave and confiscation of tobacco. Having resources available, particularly e-cigarettes, has been hugely important in helping people be comfortable with the restrictions. And training films I've already mentioned. Let's go to my next one. Excuse me a second. So in supporting our patients, I really felt that these three things were the important things: was showing compassion and respect, trying to get on side with the person. You're there to support them rather than force them. And really communicate that their needs and fears have been listened to, and obviously that means that you have to prepare the ground beforehand, leading up to all that, with all the information and resources, making sure those are available and not just promising them and then not delivering. They had to be there, following up promptly on any agreement made with the patient to ensure that all they needed to manage their tobacco withdrawal, because that is their coping strategy and the way they manage their emotions. So finally, the last stage of this in 2018, just literally before Christmas, I was the lucky lead in Harrow, and actually going down on the ward every day, several times, seeing all the patients myself, when with nurses that were there as well. So we all really got the hang of it. And I'm really quite pleased to say that there may have been, at least 30, 35 current smokers spread across the wards, and only 2 or 3 were shouting at me. And even the ones that were shouting at me and didn't want to have the conversation, I did as Mary said, and I went back, I'm on your side. I want this to be as easy as possible for you. And it was fine. And we didn't have any incidents, which was amazing, given it was leading up to Christmas. Can't take all the credit because Brent had actually beat us to it, even though they're a very, very challenging borough and a much, much bigger unit. So that was fine. So I hope that you will check out the film. It's still very, very relevant for any patients admitted to hospital. It's if you just look on YouTube and you just put in smoking and your mental health, CNWL, it should come up. And hopefully we may be able to share the new training film in a limited way. I've got the drew the short straw because I'm doing the bad example of how not to do it, and I really can't watch it without collapsing into hysterical laughter. But my colleague Claudine Pisani did a very, very good example of the next one. So really that's about it for now. Thank you.
Thanks so much, Di. Some really useful insights there, and yeah, looking forward to watching the new film. So our final speaker then is Kim Thorne from the Solent NHS Trust, so moving down south. Thanks very much. Over to you, Kim.
Hello, can you hear me? Hello?
Yes, we can hear you.
Oh, sorry about that, sorry. Good afternoon, and thank you for inviting me to be part of this webinar this afternoon. I'll try and whiz through because I'm aware of time. But really, I think as with everybody else, preparing to have smoke-free mental health wards was critical in involving all of the key stakeholders. So we needed to jointly work with everybody that this was going to affect. So obviously patients and carers, clinical staff, clinical leaders, pharmacy, our public relations, they needed to help us with the communication, our estates department, local security, public health and wellbeing services, and of course our leaders. So together with all of those key stakeholders and partners, we created an action plan, but this was driven by the needs of the mental health services. We had, sorry, I've lost the slides now. Right, okay, beg your pardon, I do apologise. Next slide, not moving. I do apologise, but for some reason I've frozen and I can't move to the next slide. Is anybody able to help? Hello.
Vicky, are you able to perhaps show the slides instead?
I do apologise for this, but my computer seems to have frozen and I'm not able to move on to the next slide.
We'll try and get the slides back working again, but maybe just carry on with your presentation, Kim.
Okay, yep, I'm sorry about that. So the 5 main issues within our action plan was communication, and we've already heard from our other speakers the importance of communication, and we used many mediums for our communication, as with other speakers. Our second action was to learn from others. So we really engaged with other trusts on the journey to learn from each other and to benchmark where we were at. The third action, we're on, in order to support our patients, we needed to make sure that we had everything in place. So we worked with our pharmacy colleagues to make sure that we had enough NRT products. We had a huge variety of products. We made sure that our nursing and medical staff received information on the relevant information that they would need. So, for example, the prescribing guidelines. We developed a smoke-free protocol, and we provided lots of information and guidance on the use of e-cigarettes and also training. And the next slide talks a little bit more about supporting the staff working within the mental health services. They needed to be prepared. We knew that this was going to be a challenging time for them as well as our service users. And to be able to support our service users, we needed to make sure that our staff were prepared. So we worked with our pharmacy colleagues, our public health wellbeing services, our Solent lead health and wellbeing nurse, and the smoke-free lead to identify the appropriate levels of training. And this included how to access the training. Our matrons were key in helping us to identify all of the staff and the various levels of training that was needed. All our prescribers and registered nurses received training from our pharmacy colleagues on the use of NRT. The standard set was that each of our inpatient areas must have 75% of their team trained on an ongoing basis in order to be able to support and be available to support our service users on admission. Okay, on to the next slide. We needed to provide clear documentation to make sure that staff were providing a consistent approach. I think in the early days, and I'm sure many trusts have experienced, the mixed messages and the confusion created an awful lot of upset for all of the people concerned. So we developed a document, a standard operating procedure, and that was talked about at length at every opportunity, and of course still is, giving both patients and the staff to talk about and share their concerns. So our implementation went ahead on the 1st of September 2017. Currently on admission, all smokers are offered a number of options, including a range of NRT, education, and e-burn. In September 2018, the use of e-cigarettes within our indoor spaces was, after review, was permitted, but we were mindful of not exposing non-smokers from the vapour created by some products. The use currently in Solent, the use of refillable e-cigarettes are not permitted due to the potential risks of unknown substances being added. Negotiation and consultation has taken place since to improve access to e-burn for patients admitted to hospital. The use of NRT and e-burn has been reviewed via a patient and staff survey regarding preferences. The overwhelming preference was e-burn. Use of e-burn has increased and the NRT usage has reduced and has significantly reduced wastage. Following consultation with a local trader, a local trader has agreed to stock e-burn to allow for easy purchase for those individuals who've chosen to purchase their own. As with everybody, patient information leaflets informing of the alternatives have been developed and disseminated. And we're working and have been working closely with our crisis teams to prepare patients both prior to admission and to continue to support post-discharge, and this work is ongoing. sorry, I've whizzed through that quite quickly. The last slide is really negotiation. I do apologise. So, yeah, we've worked with our public health colleagues. I do apologise for this. I've worked collaboratively to drive forward the smoke-free agenda and to support both patients and staff. The wellbeing services continue to support us, improving advice and support both pre and post-admission to hospital. And they're also helping to develop the clear pathways within the community. Okay, next. So finally, I think the message really from Solent is that for us, as you've heard, joint working and agreeing the actions together has been essential to our implementation and to moving forward. So that's my last slide, and I apologise for the technical issue, but my computer is completely frozen, so my apologies for that.
No worries, Kim. We got there in the end. So thank you very much indeed. And again, a really interesting presentation. So we've got a little bit of time for questions. So just the point then, picking up the point, Kim, that you made about working together. So a couple of questions about that. One was about integrating and embedding smoke-free policies into ICN strategies locally in respective boroughs, so into presumably the integrated care networks. And then another question about how a local mental health trust refers mental health service users to GPs to prescribe. And it appears that people are passing the buck, so to speak, and it's not clear whose responsibility it is, and there's ambivalence. So I don't know whether anybody would like to pick up either of those questions in the first instance.
I'm happy to jump in, and it's Mary here. Just to say, yes, I think it is a bit of a postcode lottery. Sadly, some of the local stop smoking services which were managed by the local authority have taken huge financial hits, and so that has a direct impact not only on the provision of support, behavioural support, but also on access to medication. So I think it's a bit of a mixed picture, and certainly in South London we have sadly some GPs who are not happy to prescribe varenicline, and we have others who place what we feel are unhelpful limits on access to NRT. So we find ourselves arguing on a case-by-case basis for individual patients, really, and I think that's how we're managing to get along at the moment, but it's not ideal.
Thanks, Mary.
Sorry, it's Kim here from Solent. I think we have worked with our wellbeing service, and we have a very clear referral process. So anybody that's admitted who wishes to continue that, we can refer directly from inpatients to that service, who will continue that work at the point of discharge and thereafter.
Super, thank you. Perhaps if I move on to another question, how are e-cigarettes made available quickly on admission? Are they available to purchase or supplied by the hospital? Are all NRT products available on admission day and night?
I can speak for Solent. So on admission, NRT 24/7 and e-burn we provide free at the point of admission. It's also available, so patient has the choice on admission to use NRT and or e-burn, and they're readily available 24 hours a day.
Thank you, Kim. Anyone else want to address that question? Okay, I'll ask another question, which is about how much it costs to create a trust based smoking cessation service if there's limited smoking cessation support in the local area. That might be one we have to come back on unless anyone's got a figure at their fingertips.
Well, it's Mary again. I don't have an exact figure at my fingertips, but we have now employed 12 tobacco dependent advisors at band 6, and they work across the care pathway, because what we'd observed is that patients were motivated, they were definitely interested and keen and able to quit smoking, but the challenging point and the significant point of relapse was often at the discharge point, where even though we do, like Kim has suggested, in Solent they have that system where we refer on to services in the community. We also have that, but we found it was very difficult to connect our people at the right time, so in a really prompt way. So we're now continuing to look after people after they leave hospital. So we've got a continuous care pathway, and that seems, it's in the early stages, but is working quite well. So the cost of that is, you know, a band 6 worker across the care pathway, plus of course the amount of money that we spend on NRT and e-cigarettes. And in relation to the question about e-cigarettes, I think it's important for people to have a choice of e-cigarettes, not just, you know, the e-burn does have great strengths and there are lots of advantages to using it, but sadly it does only come in one strength, which is 20 milligrams. And I think our ambition is really to help people to be able to titrate down and to be able to switch on to a product that they can use after discharge. So we try to have a much more flexible approach to using e-cigarettes.
Thank you, Mary. Again, if any of the other speakers would like to comment, please do just jump in. I think that's the easiest way. Otherwise, I will just try and link 2 questions here. What do you do when patients under sections choose not to stop smoking? And then any advice on banning tobacco from trust sites? So would anybody like to make any comments on those?
Hi, Raminta here. I suppose I can comment on the question of what do we do when the patient chooses not to stop. So the approach that we are using is harm reduction, according to the guidance, NICE guidance, PH48, and we do not ask people to stop smoking. We offer support to manage their tobacco dependence, whether by cutting down or abstain temporarily. So we do support the patient by providing, by offering behavioral support, as well as nicotine replacement therapy and e-cigarette available to the patient at all times.
Thank you very much, Raminta. Anyone else want to jump in on this point as well?
I think for us in South London, it's exactly the same as Raminta has said. The focus is really on making sure that people are smoke-free and people are not burning tobacco whilst they're in the hospital environment. And of course, if we're able to help them to find a good quality alternative, then hopefully when they're using their periods of leave, they will be able to continue with our support to do that when they go out for periods of leave or when they are discharged. So the focus is really on making sure that, you know, it doesn't matter whether you're a detained patient or an informal patient, the smoke-free policy applies to everyone, whether you're chief executive or a detained patient. There is absolutely no smoking for everyone, regardless of what your status is in the premises. And in terms of banning tobacco, yes, tobacco and tobacco paraphernalia, so that includes cigarettes, matches and lighters, are all banned items in the hospital. And this is because it's so important to remove the cues to smoking. One of the things that our patients told us is that if we store the tobacco paraphernalia in the office, it's very hard for them. We're making it really difficult for them not to constantly want to get their hands on it. So they asked us not to store it, so that it made it easier for them to create a distance between those pesky cigarettes.
Thanks, Mary.
I would agree. Sorry, I would agree with that, and I think that's the way that Solent works. We actually hold people's tobacco and paraphernalia until the point of discharge, but our priority and our focus is about making sure that the patient is comfortable. So we're offering appropriate, either NRT, e-cigarettes, or whatever is most appropriate for that individual.
Thank you very much.
Could I just quickly jump in, if that's okay, just very quickly, and just add that we absolutely don't store tobacco at all, and we absolutely don't return it to people at the point of discharge, because we feel that would undermine our confidence in them to be able to maintain any health gains that they've achieved and continue to, you know, it really gives a message to them that we've got every confidence, we believe they can do it, and we've got great ambition for them to be able to continue to be smoke-free after they leave hospital as well. So we care about them, not just when they're in hospital, but across the whole care pathway. And I think the last thing any of us want to do is to put cigarettes and lighters back into the hands of patients when they're going home after they've been smoke-free.
Thanks, Mary. So I know we've only got another few minutes before the line will be closed down. So I just want to give all four speakers just a last opportunity to say anything. I apologise because we've had a lot of questions coming in and I haven't managed to get through them all, but perhaps if I can just go around. Any final comments? So maybe Di, start with you. I'm not sure whether you're muted, Di, but any final comments? Okay. Perhaps Di's being cut off. Kim?
No, thank you, and apologies again for the technical challenges earlier.
Please don't worry, you did manage very well. Raminta?
No, thank you very much. No further comments.
Thank you. And then Mary, any final comment?
Well, thank you to Vicky and Anne and everyone involved, and thank you to everyone for joining. And I hope it was useful. I think the most important thing is that every smoker quits as soon as possible and for good, especially now in these COVID times. So good luck, everyone.
Thanks, Mary. And I was going to also thank Vicky indeed for putting this together, and other colleagues at ASH. So just a final thank you to the speakers and a final thank you for everyone on the call who participated. And again, apologies, didn't manage to get through all the questions, but we will make sure that all the speakers see those and that we'll provide some written responses as well when we have time. So thank you again for all of your participation in this seminar, and to the speakers for excellent presentations. Thank you.
Thank you.